Welcome to the entire interview of our Health Matters segment. Dr. John Burkhart joins us. He's been on our program before. Dr. Burkhart, good to see you.
Thank you for having me back again.
We're going to talk about a depressing subject, but hopefully to help encourage people to not really deal with depression, geriatric depression. Folks, as they get older, tend or can tend to deal with depression. Is that kind of a natural thing that happens to us?
I think so, but maybe even before we get there, let's talk about just depression in general, because the World Health Organization just basically came out with a statement I think in between the last time you and I talked, discussing depression, how it's the leading cause of ill health and disability. And so obviously that kind of causes some attention, right? It's also increased 18%. So if you couple that with depression and anxiety, it's responsible for, I thought the number was $1 trillion worldwide, globally, as far as care. So it obviously has a big impact. It's had such a big impact that the World Health Organization, decided to do a whole other campaign program about depression called Let's Talk. So it's becoming more and more mainstream as far as something we need to pay attention to. But it does come up, back to your question, in forms of the elderly, right? I mean, things, as we age, things change, and believe it or not, they can be susceptible to depression, even if they don't have a history of depression.
In these WHO studies and the results they turn out, do they give some why answers? Does WHO tell us why when it comes to why are more people more depressed? Is it because we're more aware of the bad things that are in the world, or do we know?
Well, I think if we kind of think about geriatric depression, just from clinical experience that I've had, a lot of different things happen. Health is a big change. Your change in occupation, maybe how you feel useful or not so useful if you're not working anymore. Maybe life circumstances. I also think it's a time when we kind of have those existential moments when we start to realize that, sooner or later in our life, it's going to end. And maybe depending on your belief system, you're going to be called back to God, or if you have another belief system, something else is going to happen. So it starts to, and another thing, your friends start dying.
And you notice that.
Yeah,
You
notice that a lot, especially, when I've done work in nursing homes, and you have these people that have longevity.
Yeah.
And so we all think, oh, it's so great, you've lived 85, 95, 105 years. But once you talk to the person like I have, you realize they've watched a lot of their friends die.
And I'll bet you've heard many times, all of my friends are gone. Everyone I knew have passed away. My doctor even passed away.
Yeah.
And they're thinking, what else is there for me?
Yeah.
So that's a natural thing.
Yeah, people they've known 40, 50, 60 years, and now they're gone and trying to figure that part out.
I would never ask you specifically about a patient by name, but is faith, and you touched on it, an important thing? No matter what their faith beliefs are, do you find people that have hope for eternity in whatever fashion they believe tend to feel a little bit better and maybe avoid depression a bit more, generally?
I have met a few people that have used their faith very well as a way to comfort them, especially in their times when they know they're passing. Because in this case, the person I'm thinking of was Christian, so they believe that when they pass away, they're going to go to heaven and they're going to be with God. So in this case, that person used their belief as a self-protective mechanism because they already knew where they were going. Most people, when they get really fearful of dying, it's because they don't know what's going to happen to them next. In this person's case, their faith kind of saved them from having that worry.
So in the time we have left, when a person of a certain age, 60 plus, comes to see you and says, I'm not working anymore, my health is fine, but I'm still depressed. And then they look at you like I'm looking at you now going, help me, doctor. What do you begin to do to try to get them on a path to avoid?
So a few things when you start seeing elderly people is you notice that they'll have more complaints about cognitive symptoms. My memory's not as good. They may not really focus on, hey, I'm feeling sad or down. They also might have somatic or physiological complaints, even though their doctor's kind of given them a clean bill of health, but they're starting to notice all these changes. And so then when an individual has that, you have to go, okay. And then there's some screening tools like a geriatric depression rating scale that you can use that maybe might help get some more information out of the person, because sometimes in the older population, if you ask them direct questions, they don't answer them how you would want to clinically. For example, if you ask them, do they have anxiety? They say, oh, no. But my doctor gives me a nerve pill. Oh, okay. So you have to figure that out. But sometimes some of those things like a rating scale can kind of help. Just ask some questions in a different way to get some more information. And, depression becomes even more important as you get older, because if you look at just healthcare costs or what it costs the individual in general, there's a Medicare study that people that had depression and chronic illness, well, they spent twice as much as just the person with the chronic illness with no depression. And we also know that long-term exposure with depression can increase your risk of mild cognitive impairment and dementia. So those are some other big factors that come into play.
I'll make this my last question. I have a theory, unproven, untested, that other than a disease that will kill you, loneliness is one of the worst things a human can experience. Loneliness can't help avoiding depression. It's got to be a part of it.
It is.
Can be.
Yeah, and I think that's when you have to look at the person and how to re-engage them in some things. I mean, perfect example, if they've been a very social person, then yes, you want to match them up with engaging them in a lot. If traditionally most of their life they haven't, well, you want to still mildly engage them, but you don't want to set the bar so high that it's really out of their comfort zone and they're not going to engage in the treatment, so to speak.
Right.
And when you even think of treatment, there's medication and there's psychotherapies. And so if you look at some of the things I think that are important to know is, especially when you get older, sometimes some of the literature says the first time that they would take an antidepressant is not very effective. It almost seems a little treatment resistant. So they might have to have a couple trials of something. Well, that can be very frustrating, right? And it might make the person want to stop treatment. That coupled with stigma. And then if you look at some psychotherapies, well, reminiscent therapy, kind of looking back at their lives and how they're doing, cognitive therapy or just interpersonal therapies seem to do very well with this type of population. So when you start to picture the person and identify them, well, then you also want to start to identify treatments that are useful for them as well.
Dr. John Burkhardt, your expertise is very much appreciated by us, and I know by our viewers as well. We learn a lot when we talk to you, and we appreciate your time today.
Thank you very much for having me again.